Hello, welcome to the part two. Just wanted to let you know in the meantime, I got the visa. So whoever would like to come to the longer version in Cochin and the practical part, you're very welcome. It's all free, definitely the lecture. So on this image here, we can see the throat of a mouth-breathing child. The tonsils are always enlarged, and there is obviously gradation. We can see here down on the left, it's called kissing tonsils when they're literally meeting. And, these poor children, they don't develop fully because they are suffocating. So on the right, we can see removed tonsils, although in many places it's becoming a little problematic. For example, in England, they require the child to have 5 infections in a year to actually remove the tonsils. The key is actually to restore nasal breathing and orthodontically expand, stimulate horizontal growth of both arches and also myofascial therapy. But we'll come back to that as well. So yes, so typical features, the tired eyes, the lips are not competent often because of the downgrowth of the trapped mandibule. It can move forward, so it goes down. So you have the long faces, the tired look, and yes, so you'll know straight away that this child requires horizontal orthodontic growth stimulation. So here we have comparison of children who suffer with obstructive airways and the ones that are diagnosed with ADHD, and apparently you can't tell the difference because possibly there really isn't any difference, because most likely they all suffer with obstructed airway. But that's another, obviously, a research to do. There is obviously a neurological percentage as well, but most of these children actually should be obligatory screened for any obstruction of the airway before they are going to be given medication like Ritalin. The CPAP machine for adults, for children, unfortunately, it puts pressure on the upper jaw, blocking the forward growth. So honestly, the best is really to start with breastfeeding, the natural stimulation of horizontal growth of the jaws, restore nasal breathing to allow the full growth rather than ending up with these problems. Also to bear in mind when we see some, facial feature, not to assume things. For example, the fact that someone has, a large lower jaw, they may still be underdeveloped in the upper arch because the lower jaw just passed through the upper. And then we have the third class, but these kids can still really suffer with obstructive airway. So the clenching bruxing, this is what you see in your adult patients who are trying to restore with all the, really rigid materials and porcelain, and it fails because you see the lower teeth here, they're growing inwards. That tongue is still really suppressed in that small space. The teeth arches are really narrow, so hence the clenching and then fracture of the porcelain. So the protocol will also give you an option to restore them in a way that we create more tongue space so that you don't end up with these problems. Yes, a little more features of the segments of the airway. I think we're going to just, yes, and here also the impact of the soft tissues, when we are obese, or is it skeletal, or is it actually something we can tackle with, a bit more exercise and just diet. The first book I read on the subject, there are plenty, and the one that really blew me away was the epigenetics by Dr. Zing, the creator of the Vivo system in America. So yes, when the patient is on the chair, we can see more features. For example, the impingement of the soft tissues of the nose. If they will tell you that they don't sleep very well and they're usually their nose, but you can have a look at these things, especially when they're laying horizontal on the chair. Interestingly, even for adults, when the orthodontics that are driven to restore potential of the patient, They use increments of 1/4 of a millimeter, which is the space between the tooth and the bone. And when we work within that physiological distance, the body actually has time to create bone. So these things can actually be stimulated to grow in adulthood. That's another aspect. We can also talk about it on our longer session. Maybe going back. When patients have these, impingement, there is a little, it's called the Cottle test, where basically you just stretch the skin around the nose. And if the patient feels, oh yes, that's much nicer to breathe, you can straight away advise them to use some nose cones, little dilators, also some nasal sprays, like this is xylitol one, which doesn't give a rebound. You can also tell them about diffusers, something to just help them to breathe better at night straight away. Some more anatomy. Okay, so when we start to analyze the impaired airway, it's not just the space behind the tongue, but it can start from the tip of the nose all the way back to the throat. So there could be anatomical feature like here, concha bullosa. This is a space in the concha which is separate. It has its own mucus, and it can occupy the nasal passage. So these things are analyzed when we are actually want to evaluate patients kind of upper airway passage from the onset. You have deviated septum. You see in here, this is a patient who has a very narrow teeth arches. The tongue is not even reaching the palate. What then happens, this section is squashed. It doesn't mean that he was hit in the nose when he was young, but that nasal cavity didn't manage to develop fully on the length, so it becomes windy. You have a deviated septum, which can impinge the hiatus semilunaris, which allows the ventilation of the sinus. And then when it's all blocked, then you get the nasal congestion, and automatically you start to mouth breathe, and that's you go on the wrong path again. So when we do our OPT, sometimes we can also have a little look what's happening in the sinus. This is a CT scan, so we can evaluate soft tissues better. But yes, we basically look at outside of the teeth. Yes, we want to help the patient to breathe through the nose. That's ultimate goal, nasal breathing. We want to give them more room in there, but also we want to pull that tongue out of the airway as well. So snoring, yes, we can see the soft palate, the uvula, and this is the wall of the throat. What a small distance that is. So when patients are snoring, this is where the vibration takes place. It's a lovely image. When patients open their mouth, when you do your checkup, you can actually see, can I even see the uvula? Can I see if the soft palate is very long? That will also prone patients to the closure. Anything that impinges the airway will play a role. So we have patients, for example, who have such long soft palates that you can't really see anything behind, so they will be also prone a little bit more to the obstruction. The evaluation of the tonsils, yeah, just a little more anatomy. Yeah, this is a lovely image from the back as well. Lovely. Okay, so I think we're going to move on to the protocol. This is forward head posture. This is when patients have their airway addressed, how it actually retracts on the spine. It's really beautiful to see. From this patient, suddenly, they become taller, and the backs don't hurt. You can actually have an impact on that. Yeah, so when they walk through the surgery and you see those features, you can also automatically think, okay, there is some compensation happening, especially with kids. You can see that very clearly. Okay, so this is a first case.